Hi viewers, now we are going to discuss the main topic, that is male infertility. That is male infertility. See, when the couples come to you with the infertility problem, you analyzed everything from the female patient. From the couples, in the wife, everything good. So we have to order the HSA, because now the wife condition is everything clear. But even though the infertility condition is going on, so we have to order HSA. HSA means husband semen analysis. HSA means husband semen analysis. Normally we have to analyze the sperm. So in the sperm we have to mainly do the count, then the moving the mobile or motility, and then we have to see the morphology. In the sperm, what we are going to see, count, mobile and morphology. So we have to do this all the condition within the half an hour of ejaculation of sperm. That's the main condition you have to remember. Within half an hour. Within half an hour of ejaculation of sperm, we have to do these three things. Now, see, now this is a very important question. The count should be more than 15 million per milliliter. 15 million per milliliter. You have to remember the count. And the mobile or motility, 40% should be needed mobility. Out of this 40%, 32% is progressively mobility. 32% progressive motility. Out of this 40%, 32% is progressive mobility. Next thing is morphology. Morphology is, this is the sperm morphological style, that is one head and one tail. This should be how 4%. Out of this 500 million, at least 4% sperm have one head and one tail. That is the morphology. So you have to remember this condition, main thing. The count should be more than 15 millions per milliliter, and the motility 40%. Out of this 32% is progressive motility, and the morphology condition is one head and one tail. We have to order the husband semen analysis. That is the very important questions. Half an hour, within half an hour of ejaculation you have to see everything. I am saying this is a normal condition. Now listen. Now if the count will less than 15 million, if the count will be less than 50 million, that is oligospermia. Normally the count should be more than 15 million per milliliter. If the count should be less than 15 million, that is oligospermia. If the mobility will less than 40% or the progressive motility less than 32%, that is asthenospermia. If the morphological condition less than 4%, or here you can mention less than 4%, or more than 97% is abnormal. This condition is called teratospermia. This condition is called teratospermia. So you have to remember the main things. Normally we can know this is less than 40%. If the progressive motility less than 32%. So normally we all will know that normal count more than 15 million per milliliter. If it will be less than 15 million, that is oligospermia, and normally motility should be 40% and the progressive should be 32. If less than 40 or progressive motility less than 32%, that is asthenospermia. If the morphological condition less than 4% or more than 97%, that is teratospermia. Now we have to know the difference. What is aspermia and azoospermia? See, normally so many people have confusion between these two words, aspermia and azoospermia. Till now, just remember the only two things. Aspermia means absence of sperm. See, both condition is absence of sperm. Both condition is represent absence of sperm. Then you can ask me how we can differentiate the aspermia and azoospermia. Aspermia means there is no sperm production. Aspermia means there is no sperm. See, there is no sperm production. And azoospermia means sperm production is there. Sperm production is there, but the sperm will not come out from the testis. It can be blocked in the epidermis or vas deferens. There is no problem, but sperm production is there, but it will not come out from the body. That is the main thing. So what is the difference between aspermia means absence of sperm, at the same time there is no sperm production, and azoospermia means that also is the absence of sperms. See, there is sperm production is there, but the sperm will not come out of the body. That's why here I mentioned absence of sperm. So now you all have to know the differences. Differences are the definition. What is oligospermia? What is asthenospermia? What is teratospermia? What is aspermia? And what is azoospermia? Now, and listen, the most common male infertility, that is most common cause male infertility, that is idiopathic. We don't know the reason why it can happen. That's sometimes you can see the question, most common cause of infertility, that is idiopathic. And don't forget, now we studied the oligospermia, asthenospermia, teratospermia, aspermia and everything, and when we call it this condition, and when the value will be less than, it will cause the symptoms, cause the infertility in the male. Now this male infertility condition can occur in the 3 stages. Listen very carefully. Pre-testicular, testicular, and then post-testicular. We studied, and then post-testicular. See, the problem is in the absence of sperm, that is relate or represented the male infertility. There is the 3 conditions: pre-testicular, testicular, and post-testicular. Now the pre-testicular is the hypothalamus pituitary problem in the hypothalamus pituitary. That is the pre-testicular means, see, before the testis. Normally, see, this is the bladder and this is the urethra, and the end, that is penis. This is the urethra and this is the penis and this is the bladder, and that is the one gland that's specifically present in the male, that is prostate gland. This is prostate gland, and here you can see the seminal vesicle, and here you can see the seminal vesicle. Now this is the testis, and here lot of branches is that is helps to the production of sperm. Finally sperm will collected and come here, that is epididymis. And this epididymis leads to the vas deferens, that is, this is vas, this is vas deferens. So please remember the structure. This is testis. Please remember this diagram always, it will be helpful to remember where the problem will occur. See, this is the testis condition. So we are studying the problem before the testis, because testis is the product, testis is the area which will help to produce the sperm. So if the problem will happen in the pre-testicular, or the problem is in the testicular, or problem happen in the post-testicular, we are going to differentiate the three things. So before that we have to remember this. Here is the urinary bladder at the end we have urethra, at the end the penis, we have prostate gland and epididymis, and the testis also there. Here is the seminal vesicle, and this is the vas deferens. Now this seminal vesicle will join the urethra. Seminal vesicle will join the urethra. Now here, if the pre-testicular problem is sure, there is no production of sperm. So hypothalamus pituitary problem. At the same time you can see the disease, Kallman's disease. Kallman disease or Kallman syndrome. Kallman disease or Kallman syndromes in the pre-testicular. This is hypogonadotropic hypogonadism. Hypogonadotropic hypogonadism. This is the Kallman syndromes we can see here in the GnRH problem. GnRH secretion problem. GnRH secretion. So if the problem occur in the hypothalamus pituitary axis, means what about the FSH level? Yes, you are correct. FSH level is low, very low. FSH level is very low. So this is the pre-testicular. Pre-testicular, we are seeing the hypothalamus pituitary problem and the Kallman's disease or syndrome, and the hypogonadotropic hypogonadism and the GnRH secretion problem. Here you can see the FSH is very, very low. Now we are going to discuss the next thing, that is testicular. See, testicular, I am writing here, testicular. Testicular, what happened means the problem in the testis, but there is no sperm production here also. Here also no sperm production, and the pre-testicular also no sperm production. Here in the problem in the testicular region. So what is this? If the heat will increase, radiation, cancer, torsion, varicocele, these are all the condition that leads to problem in the testis that make the male infertility. Not only this condition, you can see YQ11 gene mutation. YQ11 gene mutation that make problem in the testicular region that leads to infertility in the male. This YQW11 gene also leads to anosmia. This YQW1 gene. Next thing is Klinefelter. Klinefelter syndrome. See, Klinefelter syndrome, we can see 41 XSY. Here also the problem in the testis. See, whenever you listen Klinefelter syndrome, you have to remember the Pato syndrome also. How we can differentiate the Pato and the Turner syndrome. Turner syndrome means the patient is male, but the everything, character is everything same as a female. In the Turner syndrome, the patient is female, but every features happenings look like a male. That's the main thing. Klinefelter also we can see the problem in the testicular region. And the next thing, that is here Klinefelter YQW1 gene, Sertoli cell only syndrome. Sertoli cell only syndrome. This Sertoli cell, what it will do, these Sertoli cells only help to produce the sperm. So there is stopping or inhibiting spermatogenesis, formation of sperm. Increasing spermatogenesis, that is Sertoli cells only syndrome. Inhibiting the spermatogenesis, there is no sperm production. So Sertoli cells only syndrome and the Klinefelter syndrome and the YQW1 gene that leads to anosmia. Now what about here the FSH level? See, here problem in the pituitary, there is no formation of FSH. So FSH level will low. But testicular problem, brain is producing FSH normally, but the testis can't utilize it. So if the testis can't utilize, means still the follicle producing. What about the follicle level in the body, follicle stimulating hormone level in the body? Yes, increasing. These are the testicular problem. Okay. Hope you like this video. If you like this video, do like, comment, and share, and don't forget to subscribe my channel. Thank you.